All right, we'll go ahead and get started. Well, welcome all, and thank you for joining us for MST and Healing Conversations on Health, Relationships, and Care. Next slide, please. We have various learning objectives as part of this MST series. Today, we will be focusing specifically on recognizing gender-specific factors for providers working with survivors of military sexual trauma. The additional learning objectives covering pelvic health examination practices, relational factors in treatment, and co-occurring conditions such as substance use and eating disorders will be addressed in our upcoming sessions throughout this series. Next slide, please. And here's a reminder of our schedule of our series. We're offering it throughout April, every Wednesday from 12 to 1 p.m. Central. And so we hope to see you in our future sessions as well. Next slide, please. We wanted to remind you that we are offering CEU credits for psychologists and social workers. So please make sure you complete the appropriate paperwork, which we will provide in the chat here, and it also will be sent and has been sent via email as well. Do let us know if you have any difficulties accessing this information or the CEUs. Next slide, please. And before we dive into our presentation, we'd like to extend our thanks to the Wounded Warrior Project, a nonprofit organization dedicated to supporting veterans and service members through mental health care, rehabilitation, and community programming. Uh, the Road Home program is a part of the Wounded Warrior Project. And so we also want to give thanks to the Road Home program, which provides free, evidence-based mental health care for veterans, service members, and their family members. And this includes weekly outpatient services as well as intensive 1 and 2 week programs offered both virtually and in person. We're grateful for their support to make this series possible. So let's go ahead and get started with the next slide. And I'll let our speakers, Ben Schulman and Tyler Heisey, discuss their presentation entitled Gender Considerations for Providers Working with Military Sexual Trauma.
All right. Hello, everyone. Thank you for being here. Looks like a really amazing turnout. I'm excited to present to everyone today. So we'll introduce ourselves a little bit before jumping into the content. My name is Ben Schulman. I'm a counselor, LCPC in Illinois, and working at the Road Home program. I've been with the Road Home program since 2016, primarily providing therapy in our accelerated treatment models, but also more traditional outpatient therapy. Say my area of expertise is more so in cognitive processing therapy, though certainly I've experience in other evidence-based practices, and have been working with folks who have experienced military sexual trauma um, since the very beginning of working here, so over the last 10 or so years. Um, and it's been really rewarding work for me, challenging at times certainly, but um, I think the sort of impetus for Tyler and I doing this presentation is just sort of reflecting on what it's been like to be a provider who identifies as a man and working with military sexual trauma, which, in my experience has most often, though not always, most often been perpetrated by men. And so I think there are a lot of things that I've learned over the years in doing this work and hoping to share some of that with you all. And yeah, that's a little bit about me. I'll let Tyler introduce himself as well.
Good afternoon and good evening to the folks that are across the pond that are joining us today. My name's Tyler Heisey. I'm a licensed professional counselor. I have been in the field for about 2 years, and I actually served a few years in the United States Marine Corps. I'm ready to get started, Ben.
Okay. So I think we just want to start out with just sort of definition of military sexual trauma. I understand most people on this webinar are probably people who are familiar and work in some capacity with veterans and service members. But just in case there are folks who aren't as familiar, wanted to go over this. So, um, military sexual trauma defined as psychological trauma that's resulted from a physical assault of a sexual nature, battery of a sexual nature, or sexual harassment, which occurred while the veteran or service member was serving on active duty training, or inactive duty training. In terms of prevalence across genders, so estimates of 15.7 to 31.2% of service members and veterans uh, report MST. This is from stat from 2019. And amongst women, service members and veterans, 23.6 to 52.5% of women who have served report MST compared to 1.9 to 8.9% of men. So as we know, like proportionally, women are more likely to experience military sexual trauma. But sort of due to the overall gender breakdown of the military as a whole, I think there are a lot of um, people who sort of hypothesize that the total number of people who experience military sexual trauma, total number, if we break it down just in terms of men and women in that binary sense, may be pretty similar numbers, sort of raw numbers. So it just kind of helps us think about like who we might be seeing um, seeking treatment for military sexual trauma, or seeking some other types of services as well related to military sexual trauma. In terms of the treatment side of things, which is where Tyler and I are sort of most familiar, I think what we know is that evidence-based therapies for PTSD are effective overall, and are effective for people with PTSD as a result of military sexual trauma. And so in some studies, treatment outcomes in cognitive processing therapy and prolonged exposure therapy uh, were similar when comparing veterans with MST and those without MST. I believe this was in VA system data. And then there was some evidence to suggest that women might respond with greater symptom changes, symptom reductions, compared to men in terms of those seeking PTSD treatment for MST. This was actually specifically the treatment outcomes that were greater for women was in CPT, prolonged exposure. The outcomes were equivalent. And then sort of an additional piece when it comes to treating military sexual trauma that I think is important to consider is moral injury. So again, I don't want to assume that everybody knows what this is, so I'll give a quick definition that you can sort of see on the infographic there. And this is based on Brett Litz and colleagues' working definition of moral injury, knowing that there are other sort of models out there as well. But the sort of core definition for moral injury, perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. And this can include betrayal as well. And so the psychological reaction, may involve some internal conflict, cognitive dissonance with, moral beliefs, and comparing those to what the experiences were, and lead to things like guilt, shame, anger, disgust initially, and then sort of downstream effects of those experiences. I think a lot of literature, as it conceptualizes moral injury in the context of military sexual trauma, centers around betrayal is sort of a key feature that can lead to experiences like moral injury. Um, and different types of betrayal. So we think about interpersonal betrayal, that, thinking about how often perpetrators of sexual violence are someone that's known to the victim. Whether this is like a friend, someone in their unit, or someone in their chain of command. And I think, interpersonal trauma can also show up in the response after the assault itself. So, you know, not being believed or supported by peers and friends, and the feelings of betrayal, interpersonal betrayal that can come with that. Institutional betrayal, I think this can show up in terms of how these experiences bump up against values that are really uh, central to serving in the military. Um, Thinking about, having each other's back, ensuring each other's safety, trusting in one another, looking out for one another. And, when sexual trauma is perpetrated by, a fellow service member, I think, that can lead to a lot of feeling of betrayal by the military as a whole, right? We're all supposed to um, live by these values, and this is something that wasn't in line with those values. And then certainly the responses that can exacerbate harm, that can be experienced as institutional betrayal as well. So loss of privacy in reporting, um, minimization, denial of the experience by leadership in the military, or just people that they know that they're serving with, uh, and then within that, you might see victim blaming, ostracizing of the victim, and then depending on circumstances, needing to or having to, being made to continue to serve alongside a perpetrator. Um, so sort of the systemic dynamics at play, I think, can show up for individuals as feelings of institutional betrayal. And then the intrapersonal betrayal, I conceptualize this as um, sort of an internalization of some of the things that maybe they're experiencing externally. So thinking about the victim blaming that people might experience, whether explicit or implicit, I think sometimes that can be internalized and then translate into um, self-blame and loss of trust in oneself. So yeah, I think uh, moral injury is a topic that I think comes up a lot in other types of traumas. I think I hear about it a lot in the context of combat trauma, um, and in like perpetration of acts and or failing to prevent. But I think people who experience military sexual trauma can experience moral injury just as much as any other type of trauma. And that might be an important consideration in treatment and how we approach it, what we target. So next, we're going to talk a little bit about gender considerations as it relates to a client's gender. So I'll pass it over to Tyler here.
Thanks, Ben. And as everyone sees, as everyone's going to hear, some of the information that I am going to talk about, Ben has already brought up because there's a lot of things that are interlinked with one another. For example, he shared a percentage about individuals that reported MST. And within the female service member and veteran side, there is a higher reported prevalence. The 20 to 43% is one study that found women that reported MST. And I wanted to share this one in particular because it's reported. And it's extremely likely that there's a lot more that are not reporting these things for a variety of different reasons, such as the betrayal trauma that Ben brought up within a male-dominated institution. The American military as a whole is largely populated with cisgender men. And within a male-dominated institution, women that experience MST can experience and feel a breach of trust within an institution that's built on camaraderie and togetherness. And with that sense of betrayal from your teammates, your comrades, the entire institution, and it's an institution that prioritizes the mission over the individual, that can cause a lot of concerns with women besides the trauma itself, in the sense of how do I report this? And that's where the credibility concerns and minimization can come up, where there can be a fear of not being believed. That can be a large barrier to reporting what has happened. The term gaslight comes to mind for myself in the sense of dismissing reports as minor issues where a enlisted senior officer might not take that seriously. Hypervigilance in a male-dominated space, as I said, feeling on guard in their unit, if they're still in, if they are out of the service, if they're a veteran and they are seeking support at a organization, an institution that might be primarily filled with men. There is the reproductive health impacts associated with military sexual trauma. And that can be a multitude of different situations, such as fertility issues, sexual dysfunction, pregnancy, maternal health, menopause symptoms, and so much more. Lastly, gendered self-blame. With the high prevalence, the 20 to 43% of female service members and veterans reporting MST, there can be some thoughts, some beliefs of, as a woman, I should have known better. I shouldn't have put myself in that kind of a situation. And then there are societal messages, like I just said, like you should not have put yourself in that situation. These types of thoughts, beliefs can become internalized. Next slide, please. Male service members and veterans also, like with the female, underreporting and the stigma. 1 to 3% of male service members, veterans, report MST. That number is not 100% accurate, as everyone on this call has an understanding by now, because there can be a fear of reporting these things. Within the sphere of male veterans, there's the masculinity norms, the strength, the dominance. Like I said, the military is built heavily around men, and a male service member or veteran that goes through a military sexual trauma can be very concerned at their manhood, if you will, or that they failed for that identity. This can then lead into that fear of appearing weak or complicit, um, lacking that toughness as a service member, the not being allowed to share these things with his team, his unit, his comrades, even his senior leaders, because he is a man. And the last piece for male service members and veterans is the sexual identity confusion post-assault when the perpetrator is the same sex. And I wanted to bring this up, and I'm going to bring this up again later in the slides, where sometimes after a military sexual trauma happens, a man, in this case, can be concerned or confused about his sexual identity, in the sense that I spoke to an individual once that expressed some shame for having a physical reaction from being aroused by a situation that happened to him. Next slide, please. Continuing with the male service members and veterans, there can also be difficulty naming the experience as an assault. And what I mean by that is there can be things that take place in the military that are team building exercises that can be considered inappropriate in nature, and individuals, men in this case, may feel obligated to participate in whatever these games are for initiation to be accepted. And sometimes these games can have a sexual conduct in nature. Sometimes these experiences that can be difficult to name can include unwanted touching. They can be offensive remarks about the body or sexual activities. As it relates to barriers to group treatment for men, I shared this quote because it's very important. In 2013, 14,000 out of 26,000 victims of sexual assaults while on active duty were men, but only one of the 12 residential treatment programs for the treatment of military sexual trauma accepted male patients, and in that case, men were treated alongside women by Burke. I wanted to bring this up because within the culture of the military community, military sexual trauma can ignorantly be assumed that the majority falls solely on the shoulders of women, unfortunately, where men, as the slide is highlighting, also can go through military sexual trauma, and men trying to develop the courage to discuss these things can find barriers as it relates to different treatments. Lastly, gendered self-blame. I should have known better. I'm no longer fill in the blank. I'm trained as a officer. I could have fought harder, or I'm a sergeant. I shouldn't have let this happen. These different beliefs can begin to form based on these experiences that the individual has endured or survived. Next slide. Next slide. Thanks.
I just want to add real quick here that in terms of like group participation, from experience in at the Road Home program, and running cohorts regularly, specifically for military sexual trauma in our accelerated treatment program. We've always taken the approach of having those cohorts be available to all genders. And I think it's been important to do so. They do tend to skew having more percentage of women participating in those, but I think having those spaces for the men seeking care for military sexual trauma has been really, really important and creates some healing spaces for everybody coming to that program. And it's not without its challenges, but overall, I think it's been a really uh, important thing to have that space available to anybody who's experienced MST, regardless of gender. And I think it's really important when we're talking about gender to not just talk about it in terms of the binary. A lot of what we talked about thus far has been in reference to the binary. That's where a lot of the statistics are. But we know that there are transgender and non-binary service members and veterans as well. And there may even be elevated risks of sexual victimization in this population. Um, to add on to that, minority stress and institutional discrimination. So I think about things like the don't ask, don't tell policy in the military, and the ways in which a person's gender identity and obviously sexual identity too, maybe influenced the level of risk, right? To um, you know maybe have fear of reporting sexual trauma because the potential of being outed as a result of that and being discharged from service. Um, and then more recently, for transgender and non-binary folks, the executive order last year that bans transgender service members from serving in the military. I think there is a lot of great potential for harm from that. And I'll just kind of leave that there. In terms of treatment, I think trans folks, non-binary folks, uh, face misgendering in a lot of different spaces that they operate in. And the fear of that and is present in treatment settings as well. And not just a fear, I think misgendering happens in treatment settings too. Um, Whether intentionally or unintentionally, it does happen and can impact uh, how these folks experience treatment and um, yeah, affect rapport, trust in treatment settings. And then, if they're operating in gender segregated systems, I think there might be some extra vulnerability there as well. Um, we'll talk about this later about how we might be able to um, positively influence that trust in treatment settings or the settings that we might operate in with transgender and non-binary folks. But I think, the last point here, uh, this is sort of anecdotal on folks that I've worked with, but I think what I've encountered a lot is that the MST, sexual trauma, can often occur prior to any like social or medical transition. So, I've worked with a trans man who, when he experienced sexual trauma, he was presenting to the world as a woman, right? And I think that can affect how the trauma is processed. If we think about what Tyler was talking about in terms of like those uh, gender influenced beliefs that might show up. whether societal influenced or not, like I think that can show up differently for these folks. And I think we need to be mindful of that as providers or as um, people working with trans and non-binary veterans and service members. That we don't want to perpetuate the harm that can come with making incorrect assumptions or misgendering or assuming because they presented to the world one way when this was experienced, assuming that that's how they felt at the time too, right? In terms of their gender identity. So, yeah, I think just things to keep in mind as we're working with these folks and things we can be curious about. And my stance is like, I don't want to assume. I always want to explore and be curious with people, um, and allow them to sort of uh, describe how they experienced it without me assuming because of their gender identity, it must have been a certain way. So, we talked about like some of the different client gender considerations. I think uh, clinician gender also comes into play. And as I mentioned at the beginning, as we were introducing ourselves, I think this was part of the impetus for doing this is thinking about um, our experiences as providers who are men and working with this. So um, I think the overall impact of provider gender, it's obviously going to look different person to person. These things aren't going to be, um, it's not overgeneralized, right? It's not going to be the same all the time, but I think sometimes what we see is that initial engagement in treatment and development of rapport might look different. The disclosure timing, disclosure around trauma, and the depth of the disclosure might look different. Uh, and I think a lot of this has to do with the client's feeling of safety, sense of safety. I think what I've noticed is that clients might be particularly hypervigilant to uh, what they might think are potential indicators that a provider is safe or unsafe. Um, so I think this is often the case when clients might be coming in with beliefs about people of a certain gender, maybe based on their experience of sexual trauma. So the indicators that they might look to is like the physical appearance of the person they're working with, right? Things that like I don't have total control over how I look, but maybe what I do have some control over is my demeanor, my body language, uh, my word choice, and my tone of voice. Um, so those are things that people might be. This isn't exclusive just to people with MST, right? But I think when it comes to gender, this might be coming up more prevalently. So a lot of those nonverbal things that they might be looking to, but I think they may also be looking for potential signs of the provider's values or belief systems. So how we're responding to things might um, be information of what we believe, right? I think maybe we try to be neutral, but um, that doesn't mean that even if we are being neutral, it doesn't mean that people aren't sort of interpreting what we're saying and making assessments of that. So there are things that we can be attuned to within ourselves um, to try to show that we can be safe, right? We can uh, work with sexual trauma as much as any provider. Obviously, this just like as a man, like my presence, I don't think I have a very threatening presence, but that doesn't mean that someone doesn't experience me that way. And I think especially when the perpetrator of assault was a man, there may be just like my presence might be triggering it in some way. And we'll talk a little bit in a little bit about how we might try to um, mitigate some of this. But then, I think just like societal gender norms, like we've talked about previously, can impact how a client's showing up in the treatment setting. and especially in that willingness for vulnerability. I think discussing sexual content and whether that's uh, sexual content within the context of trauma or, you know, more in present day and talking about it in terms of the effects of trauma on a person's sex life. Um, I think societal norms can affect people's level of comfort with that. And some people might be less likely to initiate those topics. Um, and then I think some things I've experienced on occasion is like uh, the like depth of emotional vulnerability with a clinician who's a man. There might be assumptions about like um, how I might be interpreting that or what my values are in terms of how emotions are expressed. Um, so there might be a little bit of avoidance or suppression of like allowing that full vulnerability to be present.
And sometimes when there is those concerns that an individual may have, sometimes the gender match between the clinician and the veteran or service member is very important. And here at the Road Home, we like to provide that opportunity for folks if they have a preference for who they would like to work with, regardless of the reasons, because I recognize for myself as a therapist, I'm a white man, I have tattoos. I understand that sometimes we've had folks that might do that. And that's why we provide options, choices, and excuse me, perpetrator gender influencing that comfort. If the perpetrator was male, a female survivor, for example, might find a male provider triggering or vice versa. And those are things that we want to be very mindful of when we're working with folks that have experienced military sexual trauma. There's the other aspect of culture, religion, and other personal history factors. Every single human being is so incredibly unique, and based on who they are and their identity, that can influence certain aspects of the individual that they choose to work with. There can be traditional gender roles, for example, that comes to mind, where having a clinician of the opposite gender might feel inappropriate, or maybe they've had past experiences with an authority figure of a specific gender that shaped their level of trust in which they're operating. Lastly, the power and control dynamics and the perceived authority of the provider. Individuals within this profession are here to provide a service, and that makes us a expert to an extent, and that can come with a level of authority that is perceived. And when an individual experiences trauma, the concept, the theme of power and control might be impacted in the sense of not having control. And working with someone in a authoritative position might make them very uncomfortable, which might make them want to consider working with a different provider of a different gender. And these are things that we take into consideration at all times. And this is going to move into another slide shortly. Go ahead.
Yeah, I think as providers, something that we need to be aware of, and this isn't, I don't think, exclusive to people providing therapy. I think in other sort of support roles, you know, we anyone can experience countertransference and the sort of feelings that come up within ourselves based on who we're working with. Um, I think something that can often come up with people who've been victims of assault are like protective and rescue impulses. Um, by the way, none of these things are wrong or bad. I think they're just things to be aware of. So if we're noticing that instinct to be really protective, to want to rescue, like how is that impacting how we're approaching work with this person? Um, are we more likely to sort of give the answer, tell them, how to change how they're thinking or change how they're processing things, versus, the stance of maybe trying to help the client explore for themselves, and not sort of jump to the rescue. No, don't think that, think this instead. And I wonder where, if we have that impulse, where could that be coming from? I think these are things that are worth exploring. Is it because as a provider, I hold a belief that they're vulnerable, they can't handle this, I need to, you know, help them. I can't let them feel the discomfort. Or is it potential that like I'm trying to prove myself in some way, right? I'm trying to prove my values, show my values, and you know, oh, people said this to you, I wouldn't say this, so no, you shouldn't think that about yourself either, right? And is that for the client or is that more for me and feeling, you know, navigating, trying to avoid feeling uncomfortable myself and the uncertainty of how I'm being perceived. Um, I think anger towards perpetrators and institutions, I conceptualize this in the realm of vicarious trauma. Again, not necessarily a bad thing, just need to be aware of how our own feelings, based on what we're hearing, is impacting how I'm approaching working with this person. Um, as a provider, I might have gender-based assumptions about resilience, and I'm not going to suggest that, you know, I would think one gender has more resilience than another. I think that would vary uh, person to person in terms of the provider. Um, and maybe that's also impacted by the provider's gender, and how we sort of perceive either working with someone of a different gender or the same gender as us. Just as we talked about, like with clients, there might be some discomfort based on who they're working with and discussing sexual comfort. I think something we need to confront, not exclusively in working with MST, but just in general, our own discomfort levels around discussing sexual content. I think, part of that is doing the work on our own to, you know, be familiar with concepts and be willing to explore those issues when it's relevant for the client and important for the client. Sort of related to the protective or rescue impulses, if we're feeling the urge to be overprotective, is that pulling us away from opportunities to empower the client or allow the client to feel empowered? This last bullet point is something that I've thought a lot about over the years as I've sort of progressed as a provider. I think, um, when I'm working with someone who has a belief about men, right? All men are dangerous, or all men are a certain way, right? Uh, I think there have been times where, uh, there's trust and rapport in my relationship with the client. I'm a man, right? Like, what does that mean? Is this a piece of evidence, even if just one person that makes this all or nothing statement not true anymore? I don't think it's wrong to do that. I think that can be helpful to some clients, but I think uh, there are times where we might over rely on ourselves to challenge trauma-related beliefs. Um, and I think it comes down to awareness of the purpose again. So, uh, the therapy relationship, I think, is uniquely different than other types of relationships. So, I know there have been times where I've sort of introduced this idea and the client says to me, well, no, you're different. You're a therapist or you're my therapist. Like, you're not dangerous. Um, and we can continue exploring that, right? But I think the point is that, one person who is their therapist might not be uh, a generalizable way to challenge the all or nothing. Um, and if we're doing this, again, I want to consider why. Um, and kind of relating back to what I was saying earlier around like the protective or rescue impulses, am I doing it for the client or am I doing it for myself, to sort of signal something about myself? And I think that's an important thing to explore if we're thinking about using that approach. I think this is something that was, early in my career sort of encouraged for me to do, and I certainly have continued to uh, use myself in this context, but I try to be really keenly aware of it when I'm doing it or why I'm doing it, um, to make sure that it's really going to serve a purpose that's for the client.
And through these conversations, we want to ensure that we are being transparent and we are normalizing these conversations about the clinician's gender. For an example, how is it for you working with a white male provider? These are questions that are very important to be having with the client, with the veteran, with the service member, and not just on the first session. This is a continuous process. And like the second one, if at any point my gender impacts your comfort, we can talk about that. This is something that we want to revisit consistently throughout the process. Next slide, please. Now, what we would like to do, we would like to move into trauma-informed care through the gender lens. Go ahead. And the first point that we want to discuss is safety. Safety is always the priority. MST can strip a person's sense of safety. And within therapy, especially here at the road home, it's the priority constantly. And the physical privacy of the individual is always number one. And one aspect of that, like the bullet point says, is a predictable structure. This is the plan for today. For our accelerated treatment program, this is the schedule. This is what it's going to look like the day to day. And we want to be transparent in what the content is going to look like, be it the individual session or a different aspect. We want to use inclusive, non-assumptive language as well. This is very, very important. We do not want to, for example, name MST as rape, for example, because that might not be how the person describes their experience, and that is not a safe practice to do. So we want to broach these subjects. We want to learn from the client. How do you identify with what happened? What do you call it? How can I communicate this in a way that is supportive and safe to you? That is very important. Also, intake forms. When an individual goes into a therapeutic space such as ours or others, we don't want to ignorantly place people into a certain type of a bucket, regardless of gender, their experiences in the service, what their branch was. We want the intake form, one of the initial contact points, to be safe and welcoming for the individual.
I recognize too with that that these things are influenced by the sort of systems that we're operating in, and so ideally we can do these things, and if we're not, maybe there are ways we can try to advocate and impact change.
Yeah, thank you. Next piece is the importance of choice. One thing that I've shared with clients is I row, you steer, because of that power dynamic, that authoritative dynamic. I always try to assure with the individual that I'm working with, like, hey, I'm going to row this boat, you steer. Tell me where we're going. Because choice is something that's very important, especially within the sphere of military sexual trauma, because it doesn't always apply as the trauma happens, unfortunately. The second piece is the choice of the clinician. We talked about this one. If it's possible, individuals need to have that opportunity to work with someone that they feel comfortable and safe with. That might not always be the case. At the Road Home program, we are not 50-50% between gendered clinicians. So I've worked with a female, for example, that was very uncomfortable that she had to work with me being a white man. And through our process, with safety being that priority, giving her choice, she was able to realize, hey, he's an exception. Choice of seating and room setup is also equally important. When someone comes into the room, would you like this seat? Do you want the seat closest to the door? How are you feeling with keeping the door shut? I have this table that you can utilize to put in front of you. You can stonewall between us for a little bit, work on your documentation. All these different things can provide them choice, how to shape the environment that they're going to be vulnerable in. Choice around pacing disclosure. The veteran, the service member, they get to decide when and how much to share. Again, first bullet point, I row, you steer. We can't force the conversations to happen, and safety and choice are very important to build that trust, even if minimal at first. Last, choice behind the evidence-based modalities. Cognitive processing therapy is one that I'm very well trained in. And an individual might not want to do that type of therapy. They might choose cognitive behavioral or something else. We have to provide them the choices, explain them in a way that makes sense to help support their goals. Next slide, please.
Yeah, just to add with choice of clinician, something that we got in the practice of doing at intake is to explicitly ask people, though we can't guarantee this, do you have any preferences in terms of the provider that you work with, whether it be gender or other um, demographic features? And we also try to ask, how strong is that preference? Um, so maybe strong, moderate, mild. Um, that can give us a sense of like, okay, if someone says strong provider or preference to work with a woman provider, we'll do our best to match that. If it's more mild, we still do our best to honor that. But if we're doing assignments and it doesn't work out that way, we feel a little bit more comfortable. Okay, this person can work with Tyler, for example, and feel confident that it'll be okay. And I think the within the notion of choice, I think is also collaboration and sharing power in the therapeutic relationship. I think Tyler did a great job of explaining what that can look like, and the I row, you steer concept, I think, is about sharing that power. Um, Knowing that there inherently is a power imbalance in therapy, trying to avoid an authoritarian stance. So ways we can do this is like using inviting languages. Um, hey, would you like to share what you did for homework? Just asking it as a question as opposed to, all right, take your homework out now. We're going to look at that. All right. I think this can also look like asking permission for things. If I have a question that I want to ask that I know might be about some like sensitive areas, I might sort of just ask, hey, would it be okay if I asked a question about this? Um, and I think we can be inviting, we can ask permission while still being directive. Uh, a lot of the evidence-based therapies follow a pretty specific structure and require some level of directiveness from a provider. And so we can still guide that process and be directive in that process while still um, being collaborative. If I pose something as a question, would you like to share your homework? And they say no, I asked the question. I've got to honor that response, right? Now I'm going to explore that, and okay, well, what makes you not want to go through the homework right now? Is there something else you'd rather be using this time for? What's going on, right? But if I ask a question, would you like to share the homework? They say no. I'm going to say, well, can you take it out anyway? That sort of defeats the purpose of asking in the first place. Um, And then, Tyler talked about this in terms of choice of evidence-based practices, but, shared treatment planning, whether that's about the type of therapy that we're doing or how we're implementing the therapy, how we're planning out the course of treatment, always trying to be inviting of, what do you think we should be focusing on? And I might ask, would it be okay if I share my opinion, if I share my recommendations and giving rationale for that? But making sure that they have a say in that as well. Tyler and I also wanted to share, as we have throughout, some like anecdotal experiences in navigating gender dynamics as providers who are men. So I'll let Tyler share his first, and recognizing time, Tyler, we might need to be
I'll be
um,
I'll be quick with the
quick
novella.
with it. Yeah.
Okay. So I was one example, I was working with a middle-aged cisgender white male veteran who first presented with me, and he was very protective and like aggressive in his posture, behaviorally, his tone of voice, things like that. And within the beginning of our conversations, he's like, just so you know, I could take you out. And it's like, okay, I appreciate you letting me know that. Hi, I'm Tyler. It's nice to meet you. And he ended up reporting to me that his perpetrators were white men that looked like me. to include the hair or lack thereof, tattoos, even the body build, the compensation of my size. I'm not saying that word right. Anyways, I reminded him of his perpetrators and this relationship that we shared for 2 weeks, our therapeutic relationship, took a lot of safety and choice on his part. And I explained to him, like, hey, what we're working on right now, let's plot some points on a map. Let's figure out the goals. Let's figure out how we're going to get there to best support you. And through this process, he was able to build that safety with me. The next one is middle-aged cisgender white female veteran. Within our second session together, I shared she told me that I had the same name as her son, and her son was the result, he was the result of her rape. That's the word choice she utilized, rape. Our relationship together required multiple barriers for her in the sense that she sat in one corner. She had my portable table in front of her chair. She put me in my rolly chair by my desk, far away from her. She had her binder, her coffee cup, her water bottle. She had a multitude of barriers to keep herself safe. And throughout our work together, we ended up sitting next to each other, like within arm's reach, having conversations. And she shared that she was able to work through these beliefs that she had and had this form of trust and safety. I'm done. Ben, go ahead.
My first two examples are from pretty early in my career. So I just have a couple keywords for myself there. So um, within like the first few months of working here, beginning of my career, my first time working with someone who had experienced MST, I believe. I walk into the office, just sort of like not really thinking about it, and do as I would always do. We walk in the office, I close the door, and the client had a panic reaction to that, to me closing the door, and not something I'd really thought about before then. Um, and we were able to navigate it, right? We sort of shared in the power dynamic there, and um, there were a couple of the early sessions where we decided together to leave the door cracked, right? With informed consent of like, hey, there might be people walking by. This might impact confidentiality in that way, but it's what she needed to engage in the work a little bit. And then once we got to know each other a little bit more, trust was built. We were able to continue for the majority of the time with the door closed, and the work went well. Um, Another client, this was maybe a year and a half into the work. We were doing cognitive processing therapy and doing ABC worksheets, so activating event being the trauma, identifying beliefs about that and consequences from that. Um, the client was often identifying sort of beliefs about this happened because of the patriarchal system that we're in, or the world is set up in a way that puts me as a woman at a disadvantage, right? Or makes me susceptible for these things. Um, and uh, Eventually we got to a point where I think I said, okay, well, these things that you're describing, we can just treat these as facts, right? Let's move these to the A column. What do you think about, what are your beliefs about these things being true? And I didn't know that this would be the case, but doing that had such a big impact for her in trusting me. And I didn't know that she didn't trust me. It felt like there was trust, there was vulnerability there. But she told me later on that like before that moment, whatever I represented to her, she did not trust me. Right. And just that simple act of just acknowledging truth in what she's saying, not treating them as stuck points as we would in CPT or distorted beliefs, was huge in helping her sort of get what she needed out of treatment. And then this last one was more recently. This was working with a man who had experienced some interpersonal trauma. Um, and he really struggled with having a male therapist. And the reason was, he felt like my demeanor, my responses weren't conveying empathy. I was feeling empathy, but it wasn't being conveyed to him. And the belief there that like because you're a man, because of how you've you know developed in this world and how what men are taught, like you're not capable of feeling empathy for me. And it was a really challenge to work through this. He's someone who, yeah, I had to like give a lot of choices to. I think it didn't look like treatment as usual. We had to make a lot of adaptations throughout the work, but um, I think by the end, uh, I don't know that he fully liked and trusted me, but it was enough that um, he was able to continue working with me and do some work on himself. And I think we were able to end at a place where, um, he could feel supported by me. So hopefully these are some helpful examples of navigating gender dynamics. And again, from the experience of Tyler and I being male clinicians, I think uh, just trying to share our some of our lived experiences for those out there who might be doing this work.
And
I
we
know
also
we're up against time here, but yeah, there's some key takeaways.
thank you everyone that participated, that joined us today.
Yeah, yeah, really appreciate everyone being here. Um, I don't know if we have time for questions, but it's really heartwarming to see such great turnout, and I hope this was helpful and doing whatever work you do out there and helping folks with MST who've experienced MST.
Thank you, everybody.
Meridiana, anything you need to jump on for?
No, if you all want to answer a question, I can ask it, but if you all have to go, then that also makes sense.
I'm available to stay on if folks.
I can stay on.
Yeah, because I can ask a few questions from the chat in case other people can stay on. There were some questions regarding groups. If there's time, can you share about gender dynamics as it relates to conducting group therapy with those who have experienced MST? And then there was also another question about um, any examples in which there's a mixed gender cohort, and if those groups have been healing, examples of
Mhm.
that.
Yeah, I can speak to the second question first. I think there are a lot of examples that come to mind for me of times when it's been really healing. I think for um, I think especially when we've had cohorts where there have been multiple men, like men and women in a cohort, as opposed to just like one male participant. I think for the men, it's been really helpful and healing to um, sort of get to engage with someone else, another man who's experienced something similar, and maybe have some sort of uh, shared beliefs about trauma and or experiences, to know that they're not alone in it. But even when there is only one man in the cohort, I think for the male participants, still helpful to be in a space that's focused on um, healing and processing sexual trauma in general. Just maybe a lot of times their prior treatment, prior groups have been like more general, right? Not specific to sexual trauma. Um, and then I think for uh, women as well, who might have beliefs over those overgeneralized beliefs about men, um, I think being able to experience people in uh, fellow veterans, service members, and people who've experienced MST in the same cohort, um, and have a uh, a positive experience with them has helped them sort of re-examine the all or nothing version of those beliefs. Um, so yeah, I mean, those are like the themes that have come up sort of time and time again as we've had these mixed gender cohorts. Tyler, do you want to tackle the question about like being a group provider in those
Yeah,
perspectives?
absolutely. So within the group sphere and being a group facilitator, group provider, here at the Road Home, we always have two providers, two group facilitators present. And to take that a step further, they are not both the same gender. Typically, it will be no more than one man as a facilitator. And this is recognizing one, we operate with two folks because if something happens with a client, one of the group facilitators can step out with them. Besides that piece, just facilitating group, everyone's showing up for a variety of different reasons. And within the space of military sexual trauma, the group facilitators don't know the complexities of the individual veterans service members, and having two different gendered providers, facilitators can feel a lot more safe because of whoever the perpetrator was or what happened to the individual. So having two different people there can provide that safety, the choice, all of the things that we've been talking about, where they can feel maybe a little more comfortable to talk to this person than to talk to me or vice versa. Anything you want to add to that, Ben?
No, I think you nailed it.
Okay.
Yeah, thank you so much. And then there was another question about, are there any EBT somatic practices that you offer? Trauma experts are continuing to talk about healing, not just symptom management, incorporating somatic EBT approaches. If so, are you finding any differences among genders with these approaches?
Yeah, so I think I can't speak to that. I don't have much experience with that. I think, yeah, the majority of my experience is in more the cognitive behavioral treatment approaches. Um, I think in some of those, there's like the interoceptive exposure pieces of um, sort of eliciting physiological reactions associated with emotions as an exposure exercise. So, yeah, unfortunately, I can't speak specifically to the question. Um, but I imagine some of the themes that we covered would translate to most types of approaches, just in terms of how we're giving choice, how we're collaborating, and creating a sense of safety.
All right. Well, thank you so much. That's all the questions. And thank you so much for your presentation today. And for all of you for attending, we hope to see you at our future talks in our series. Feel free to reach out to us if you want further information about our programs or if you have any questions related to the CEUs or certificates of completions.
Thank you, everybody.
Thanks, everybody.
All right, I'm going to pause the recording here, and I think we're all good to leave.